Hi guys, we are back and we're going to be talking about pulmonary content today. This is going to be a little bit of everything, talking about COPD and then just the basic mechanisms of breathing. So we'll get into it. So basic mechanisms of breathing, inspiration. So we have the active process, which is just the inhalation, which is just a primary active process that requires energy. You got to have to be able to breathe. It requires energy, right? So it's pretty easy to remember. You've got to have your diaphragm contracting, and you got to have intercostal muscle movement, airflow to the lungs. Breathing or respiration is a vital process that involves the movement of air into and out of the lungs. The process allows for the exchange of oxygen and carbon dioxide between the atmosphere and the bloodstream. So breathing's pretty important, right? The mechanisms of breathing can be divided into two main phases. So inhalation is that inspiration, and then the exhalation is the exhalation is the expiration. So we're inhaling and we're exhaling. So inhalation, that's how we're breathing. Our diaphragm is contracting. We are using our intercostal muscle movements as we're breathing in, right? And our airflow into the lungs. During expiration or exhalation, that is when we are breathing out. The muscles are relaxing, the diaphragm is relaxing, airflow is coming out of the lungs. So that's just some basics to get us started in this content. During vigorous activities or exercise. So if you are at the gym, what do we think that we're going to be happening? We're going to be elevating our inhalations, and our exhalations become a very active process. So if you were going to go outside and start jogging, we're going to be, that's when you kind of start going, that's where we are breathing in and out a lot. And then that's when we're really going to start using our accessory muscles as well too. So and sometimes after you're done running, that's why your abdominal cavity and muscles might be, a little bit in pain because we've been breathing so fast and heavy. So that's our diaphragm that we just talked about. So gas exchange. So gas exchange occurs once air reaches the alveoli, and oxygen diffuses across the alveolar membrane into the bloodstream. So while carbon dioxide diffuses from the blood into the alveoli to be exhaled, this is where the gas exchange is driven by differences in partial pressure of the gases. So that is how we are having gas exchange. So now we're going to talk about some pulmonary diseases. So we have two main types of pulmonary diseases, and they are classified as either obstructive or restricted. So obstructive has a decreased FEV1, and that's indicating an airway obstruction along with a low FEV1 FEV ratio of 56%. And then restricted is an FEV1 FEC ratio above 70. So obstructive has a low FEV1 ratio of 56, and then restricted is above 70. Okay. So we're going to do a case study of obstructive pulmonary disease. So we have a 58-year-old male. Medical history is a long-term smoker. He's smoking about 40 packs 40 packs of cigarettes in a year. He was diagnosed with COPD 5 years ago. He has dyspnea on exertion, so it's that difficulty breathing while he's, maybe walking. He's got a persistent cough with sputum production, and he's really wheezy in his lungs. He has an FVC, that's that forced vital capacity of 65%. He's got an FV1, 40% of predicted, and his total lung capacity is about 120%. So how are we interpreting this? Well, the decreased FEV1 and FV1 FVC ratio indicates that he has significant airflow obstruction. And that is typical of COPD, as we know, because it's obstructive lung disease, right? The increased total lung capacity and residual volume reflect the air trapping due to the narrowed airways. So in COPD patients, we know that they have a lot of air trapping, and we'll get into the different types of COPD too. But in this particular case, this gentleman, he was diagnosed with 5 years ago with COPD. He was a long-term smoker, which is the number one thing to happen when you have COPD. And so smoking is the number one leading cause. Sorry, I lost my train of thought. And then he's got that persistent cough. And then his forced vital capacity is a lot lower than the volume reflected due to the narrowed airways. So that's how we interpret that. So now we have a restricted pulmonary disease case. So we have a 42-year-old female diagnosed with pulmonary fibrosis secondary to autoimmune disease, progressive shortness of breath, dry cough, and decreased exercise tolerance. So pulmonary function tests reveal that this lady has a forced vital capacity of 50%, and then her FEV1 is 45%. So we are interpreting that since the decreased of FVC and total lung capacity confirms a restricted lung pattern disease, which is characteristic of restrictive pulmonary diseases as well. Okay, so asthma. Actually, before I go on, because I don't think some of this content actually has the different types of COPD, but one of the things that I did want to just point out here really quick, because I'm not sure if this will continue in this area, but there's two different types of COPD. One is chronic bronchitis, and then the other one is emphysema. And your chronic bronchitis is going to be more of like your blue bloater. That's where you're going to end up having a lot of the signs and symptoms of the edema in the bilateral lower extremities, as well as like cyanosis, especially like a big old nose, because they are their nose is automatically expanding due to the high demands of oxygen that their body is requiring. And then in emphysema, they're typically going to have a barrel chest. That's notably the telltale sign of differentiating the symptoms, as well as they are going to be fairly skinny typically, because they are exerting so much oxygen and CO2 that they are typically a lot skinnier, but they're going to have a big old chest because of that too. So those are just some telltale signs of that I wanted to point out. Okay, so now we'll talk about asthma. Asthma, the airways are constricted. So there are two different types of asthma, or not two different types, but two different differentiating ways to define that. It's intrinsic or extrinsic. So intrinsic asthma is triggered by something external or internal, such as anxiety. So somebody might have intrinsic asthma if they are going to be taking a midterm exam and they need to use their bronchodilator during the exam because they're having an intrinsic reaction such as anxiety because they are nervous about answering the questions, or they're nervous about that they feel like they're going to fail their exam, that could be a rationale for intrinsic asthma. Okay. And then extrinsic asthma would be triggered out something in outside environment, something in the air, dust, mites. So this is more of the one that we really think about, mainly patients having exacerbating would be that extrinsic. Their asthmatic symptoms are triggered by environmental issues such as, we just said pet dander, dust mites, maybe pollen, and then they really need to get their inhaler out and use their bronchodilator. The pathophysiology of asthma, again, would be airway inflammation, bronchoconstriction. Of course, that's why we want our patients to use that bronchodilator so we can reverse that constriction. They might have some airway hyperactivity, airway remodeling, and then mucus production as well. Asthma is a chronic inflammatory disease where the airways are characterized by recurrent episodes of wheezing, breathlessness, which they feel like they just can't get enough oxygen. They feel like they just can't breathe. That would be that breathlessness. Their chest might feel really tight and they might start coughing. And this is actually where the complex interplay of genetic, environmental, and immunologic factors that can actually lead to airway hyperactivity and inflammation and obstruction. So asthma is primarily an allergic condition. So that's the immune response, is where it's typically an allergic condition, which we talked about the extrinsic factors of if they are exposed to certain allergens such as pollen, pet dander, or just outside pathogens. And then the immune system responds by activating immune cells, maybe T helper cells, which release those cytokines, which is causing that immune response. The cytokines promote the activation of the inflammatory cells, and that's where they release the inflammatory mediators, which is causing that histamine, prostaglandins, which is now contributing to the airway inflammation, leading to the bronchoconstriction. So now the bronchoconstriction has happened where they cannot get air in. They feel like they cannot breathe because that muscle is now contracting because of that inflammation that was released during that asthma attack. That's actually causing bronchial smooth muscle contraction. That's leading to more of like a stenosis or a narrowing of the airways, but it's that stenosis or that narrowing is just at that time during that bronchoconstriction. That is reversible. And they're needing that increased airway resistance. So that bronchoconstriction is leads to the increased resistance to the airflow, which is making it harder and more difficult for that patient to be able to breathe. So that airway hyperreactivity, that's typically triggered and led by exaggerated bronchoconstrictions and increased symptoms, even at low levels of exposure. That's often seen such as allergens, exercise, maybe cold air intake, smoke, and maybe some strong odors. And then airway remodeling, that could be more of like a fibrosis, like a subepithelial fibrosis, maybe like a thickening of the airway walls, or maybe that goblet cell hyperplasia, which is more of like that increased mucus secreting cells that's causing an exuberant, excessive amount of mucus production. And then, of course, regular mucus production, an excessive amount, obviously is going to further obstruct the airways and causing more wheezing and that coughing symptoms. I'm trying to expel that mucus out of the system, out of the lungs. So, which we kind of already talked about, basic symptoms of asthma, pretty easy. There's nothing crazy about these at all. Wheezings, dyspnea, chest tightness or pain, coughing, and increased mucus production. Okay. How do we treat an asthma attack? We're going to use short-acting beta antagonists, or SABAs, which is going to relax the bronchial smooth muscles and quickly relieve bronchoconstriction. Okay. So this would be more of like your bronchodilators, things like that. Albuterol is a typical one a lot of people use during an asthma attack, or either with a inhaler or maybe even having it on a mask. Some patients might need to use like a neb treatment for that. So client education for asthma, obviously recognize the symptoms. We need to stress the education to patients with asthma, that they have got to have an idea and an understanding of asthma symptoms, so that way they're able to recognize it, so that way they can get the medication for treatment as quickly as possible, so we can get that oxygen flowing to the brain, into the lungs. We want to remind them to avoid triggers, relaxation, stress management. We want to make sure that they take daily management strategies, medication schedule, staying away from allergens. You know, if somebody's allergic to pollen, probably not the best idea to go to a flower shop, or if somebody is highly allergic to candle scents or like incense, you're probably not going to go to a shop or a gift shop or things like that are going to have that, because that's only going to trigger you. So we need to have an understanding to, have those patients recognize those triggers, so that way they can manage their daily lives. And we want to make sure that they take specific steps during the asthma attack and remain calm, which is very, very important. When somebody can't breathe, they get very, very nervous. But this is why education is exponential and very, very important, to ensure that they are properly educated and understand the need for medications and how and when to use them. We're going to talk about interstitial lung disease and what that is. So, interstitial lung disease refers to a diverse group of lung disorders that primarily affect the interstitium, the tissue, and the space around the air sacs, which is the alveoli in the lungs. So the pathology of interstitial lung disease involves a complex interplay of inflammatory processes, which are basically like scarring. Like we think of like fibrosis, like scarring. And it's a disruption of normal lung, and basically in a detailed overview of this would be interstitial lung disease. It can be triggered by various factors, such as like asbestos, silica, or coal dust. It could also be like infections, drug toxicity, and then this normally ends up leading to a lung tissue damage. The fibrosis can cause altered lung compliance due to the scarring and the inability of the lung to expand. Because that's obviously, if you have scarring or fibrosis, it's going to make it a lot more difficult for the lungs to inflate, right? Which is going to lead to more of a restricted lung disease, right? Because they're damaged. And if they're scarred, there's no repairing that. So just think of it in that way. Fibrosis, I mean, you can't really unfibrose something. It's kind of done for. A disruption of alveoli damage, like we talked about, interstitial fibrosis disrupts the normal architecture of the alveoli, leading to the formation of more of a honeycomb lung, which is a characteristic pattern seen in advanced interstitial lung disease. It's a honeycomb lung. I don't know what that would even look like, but just remember honeycomb lung is a characteristic pattern seen in advanced interstitial lung disease. And that's typically seen on imaging studies. Of course, we just talked about fibrosis is progressive. You can't unfibrose something because it's damaged, it's scarred. So what's going to happen is that the alveoli is going to collapse, right? It's going to become less functional. It's going to lead to impaired gas exchange, reduced oxygenation in the blood, which we know, is just not good all around. We have to be able to breathe. And if something is fibrosis, it's only going to get progressively worse. So this is very, very serious. If gas exchange impairment happens, we're going to have reduced diffusion capacity, right? We just talked about that. It's going to have a reduced capacity for oxygen, carbon dioxide across all of the alveoli capillary membranes. And that's going to cause what? Hypoxemia, which is going to have that low blood oxygen levels. If they have low blood oxygen levels, they're not getting enough to their brain. Probably some other signs and symptoms we're going to see is probably less consciousness. Maybe they're going to have some alterations in mental status. And it's probably going to lead to a risk for falls, especially for, we're talking about this is happening more in the elderly population. It's going to put them at more risk for falls as well. This could also be a ventilation perfusion mismatch, which is causing fibrotic changes that can further compromise gas exchange and leading to respiratory symptoms. So interstitial lung disease, some physical findings we're going to see is progressive dyspnea. So they're going to progress to having shortness of breath, especially with exertion, and eventually at rest as the disease progresses. So at first, they might have noticeable difficulty breathing when they are walking, maybe just, walking to the outside to their mailbox. And then as the interstitial lung disease progresses and gets worse, and they might be just sitting in a chair and having trouble breathing, okay? So you're going to see diminished breath sounds in this patient. They're going to present with a dry cough, which is very common. It's going to get worse over time. And of course, with that less blood flow and having that lack of gas exchange impairment, they're going to have fatigue and they're going to have weight loss. So patients may experience fatigue, malnourished, and unintentional weight loss as the disease advances. So that's really important to know too, because there's probably going to be some metabolic issues as well, possibly. Okay. All right. Now we're going to talk about COPD again. So hopefully maybe we can learn a little bit more about this too. I know we talked about this just for a minute, but I hadn't really looked this over yet. So I wanted to make sure that we touched base on some of these. So COPD, this is diagnosed based on a history of symptoms. So physical examination, chest imaging, pulmonary function tests, and blood gas analysis. So pulmonary function testing reveals airway obstruction is decreased in the FEV1, and that is progressive and unresponsive to bronchial dilators. And so earlier we talked about the two different types of COPD, which is emphysema and chronic bronchitis. Some stagings of COPD is staged on a GOLD guidelines, and that's based on the degree of airway limitation. So gold 1 would be mild. That's going to be 80% predicted on an FEV1. Gold 2 is moderate, about 50%, but definitely no more than 80%. Gold 3 would be severe, and that would be 30%, but no more than 50. And then 4 would be the very worst, very severe COPD stage, and that would be with no more than 30%. And the COPD management. What's the number one thing that we said that causes COPD is smoking. So management would be instructing and educating our patients that they need to have smoking cessation, stop their smoking. They need to continue using bronchodilators and inhaled corticosteroids. We can have them do pulmonary rehab, oxygen therapy. Again, remember, most of these people are probably going to be on oxygen anyways. And it's not out of the norm for their oxygen, to be more in the higher 80s, just because even if they're on oxygen, it's very rare for people with COPD to have, like 95, 96% or even higher, because their lungs, they already have lung issues. So just remember that higher 80s, lower 90s is acceptable for somebody to have if they have COPD. So vaccinations, manage exacerbations, lifestyle modifications, and then regular follow-ups and monitorings. So COPD is a progressive respiratory disease that's characterized by airflow limitation. It's typically caused by long-term exposure to harmful particles or gases, most commonly from smoking, like we said. Management of COPD focuses on relieving of symptoms, improving quality of life, and preventing exacerbations before they happen, and slowing disease progression. So smoking cessation. Why is this so important? This is a crucial step in managing COPD, is to stop smoking and avoid exposure to other harmful pollutants. And we're talking about pollutants. Another pollutant could be like smog in more of those southern states, even smog or pollutants from if in like urban and in city areas, there is a higher population of patients that have COPD that live in urban or southern states due to that, which is kind of interesting. Interventions, obviously, for smoking. If somebody has smoked, for 40, 50 something years and they've developed COPD, they can't just stop, right? So we need to offer them interventions so that they can actually work towards a goal, and we want that goal to be obtainable. So it's important for us to offer counseling. It is important for us to do some nicotine replacement therapy, maybe through a nicotine gum or a patch. And we might be able to also add prescription medications, buspirone, and then which would be that Wellbutrin, which is also an SSRI, which sometimes we give patients for anxiety or depression. Well, that's also a smoking cessation medication. And of course, we can recommend support groups and programs as well. So some pharmacotherapy for COPD, which would be bronchodilators. That would be your SABAs and your LABAs. So SABAs would be more of your albuterol, which we said earlier. That's for quick relief of symptoms. That would be like that inhaler before your test, so you don't have an extrinsic asthma attack. This is also used in bronchodilators. This is also used in COPD, for your SABAs. And then your LABAs, that long-acting beta agonist, that's more of your long-term control, your salmeterol or your formedrol, okay? And then your anticholinergics, that's that short-acting, your intrapodium, and your tepodium, and that's going to reduce the bronchoconstriction. Inhaled corticosteroids, those are used for patients with frequent exacerbations that help reduce inflammation and prevent flare-ups. Some people might actually use combination therapy. So they might benefit from a combination of bronchodilators like ALABAs and ALAMAs. So somebody might have ALABA, which we said was that solumedrol, and then they might also have a LAMA or other inhaled corticosteroids. So pulmonary rehabilitation also is very important, using a comprehensive program that includes exercise, training, nutritional counseling, and education about the disease process, and just the benefits and how it can improve physical and emotional well-beings, increase exercise capacity, and reduce the symptoms. The oxygen therapy, that would be for patients with severe COPD and low oxygen levels. And especially if you're determining that by like an ABG measurement. Our goal is to maintain oxygen saturation levels above 90% during rest and activity, but that's not going to be uncommon to see in those upper 80s like we talked about before. But we want to try to maintain oxygen above 90. Vaccinations are also really important, making sure that our COPD patients receive their annual influenza vaccinations, and pneumococcal vaccines are recommended to prevent respiratory infections, which can just further exacerbate COPD. Management of exacerbations recognition is essential. Educating patients to recognize early signs of exacerbations, such as increased breathlessness, cough, and sputum changes, and then just developing an action plan for them, to develop an action plan that includes the use of bronchodilators, oral corticosteroids, and antibiotics if they start getting some type of infection. And then lifestyle modifications, that would be just making sure that they're getting a good diet and nutrition, and it's balanced to help prevent weight loss and malnutrition. And then physical activity is encouraging regular and supervised physical activity to enhance endurance and their strength. Now we're going to talk about emphysema. So this is where damage occurs in the alveoli. This is where it impairs gas exchange, and it's an issue is in the expiration that they can get air in, but they cannot get it out. So that is why it is very common in these patients to have a barrel chest, because they cannot expel the CO2. And that's what causes the air trapping. Some education for them would be to use pursed lip breathing, encourage that as well. There is a couple different types of emphysema. The centroacular emphysema, that primarily affects the central part, particularly in the upper lobes, and is most commonly associated with cigarette smoking and is often seen in smokers. And then pancular emphysema is often associated with an alpha-1 antitrypsin deficiency, where it's a genetic disorder that affects the lungs. There is a distal acular emphysema, and that is normally associated with smoking, but it may also occur in individuals without a history of smoking, but it's often linked to spontaneous pneumothorax. A typical x-ray for a patient with emphysema are going to see that the it's going to have an appearance of a barrel chest. So just remember that they're going to have a barrel chest, and that's what it's going to be. It's going to be a flattened diaphragm, and the posterior chest is going to be increased in diameter and flattened looking. Chronic bronchitis is a productive cough with copious amounts of sputum. So that means tons and tons and tons. It's copious. Difficulty breathing, wheezing, rhonchi, cyanosis of the skin and mucous membranes. Damage occurs in the airway, not in the alveoli. And that's pretty much it for bronchitis, chronic bronchitis, besides the fact that I do want to point out that they're typically known as blue bloaters, which is getting where that cyanosis is. And then it doesn't really talk about too much about the edema, but they normally are heavy because they're everywhere is being affected by the exchange. And their nose is normally bigger too from the need of more oxygen demands. And that wraps this content up, and I'll be on the next video.